This conference will now be recorded.
It's John Antonucci. This is AnCan's high-risk metastatic advanced prostate cancer group for the 12th of November, 2024. We're going to start group in a minute, but first just acknowledge that we have support from J&J, Myriad Genetics, Telix Pharmaceuticals, Blue Earth Diagnostics, Foundation Medicine, and Novartis. Support that doesn't require us to endorse any products, and we're grateful for that. I also failed to mention in time for our new guy, James, that this meeting is recorded. If you're uneasy with that, you're welcome to alter your name, blank your screen, anything else that you want to.
I'm okay with it.
Okay. Now, before we get started with James, I want to remind everybody that AnCan is updating its survey. The last survey, I think, is 3 years old or something like that. No, maybe even more than that. Rick will know. It's a survey that helps us get feedback from all of you, and this year we're doing it for all the other groups at AnCan as well. We want to know how we're doing. We want to know what suggestions you have. We want to know who you are, where you come from, how we can meet your needs. And if you got our survey request, please fill it out. It only takes about 10-15 minutes. It'll help us a lot. You can do it anonymously, or you can fill in the details however you want to. If you didn't get a survey request, please let Rick know on the chat.
Well, what I'm going to do is I'm putting the survey link in the chat right now.
Even better.
So it's going to everybody. Well, the survey link will be also in the post on YouTube. We really need you guys. We don't ask a lot from you, and you ask quite a bit from us, and we're happy to give it. So this time we're asking from you, and we really need everybody to fill out the survey, and that includes all of our great participants who watch the recording. So if you're watching the recording right now, you'll find the link in the either in the blog post or in YouTube. And we need the recording people, because we don't have a good handle on you. And this survey is going to be used not only to guide us in our programming, but we'll also take it to medical conferences and show how we give the patient voice, more volume. So that's it. So please, it's John says 10 to 15 minutes. I would say 5 to 10 minutes from the experience people have had. Won't take you very long. It's all multiple choice. You don't have to identify if you don't want to. You can make any extra remarks at the bottom, like I talk too much, like Rick talks too much, or whatever you want. That's just fine. And just one other thing, John, Mark Valens is on. He was sort of on and off, and I know he needs time, so put him down, please. Okay.
Yes, okay.
Mark Valens. Sorry, Mr. Valens.
Okay. So, James, I'm going to take about 10 minutes to get some background from you, make sure you're in the right group. And you referred to us by Cliff, was that right?
Yes.
Okay. Well, welcome to the group. How old are you?
76.
Where do you live?
Clinton, Maryland.
And do you happen to be a vet?
Yes, I am.
You have a military bearing about you, I think. Tell us when you were diagnosed, James. You go by James, right? Not Jim, or you wouldn't have typed it in, right?
It's okay. Jim or James is fine.
Okay.
Yeah. I was first diagnosed in July.
Hold on just a minute. Hold on just a minute, James. We got a bunch of feedback there. I think it was from Frank's microphone. I'm not sure. Let's start again. Okay, I see. Start again, please. You were diagnosed when?
Okay, I had a biopsy in July, and they found just a little speck, which they said it wasn't even worth treating. And then in October, I had another biopsy on my lymph nodes, and that's when they found something. And on October the 29th, when they informed me of it, I started taking treatments right then.
Tell us a little bit more about that biopsy. Do you remember any details, like Gleason scores or type of cancer or how many cores were positive, any of that stuff?
Okay, the only thing I know it was prostate, and as far as the Gleason, I don't know at this time. I don't remember what it was.
Was there anything mentioned like whether it spread outside the prostate, whether there was extracapsular extension or seminal vessel invasion? Any words like that sound familiar?
Well, they did say that it was in my lymph nodes.
It was in your lymph nodes, but
Yes.
how did they get, I'm a little confused how you got a lymph node biopsy out of a prostate biopsy. Did you have an MRI that showed a bad lymph node or something?
No, not before I had the biopsy. I didn't. When they did the biopsy on my prostate, they didn't find nothing. They said they found a little speck,
Right.
and my numbers was up. So that's the reason why they went to the lymph nodes.
What was your number, your PSA
37,
number? How much?
37, 37.
37, yeah. And what was it before that?
I don't know. I don't know.
First time you got a PSA test?
When I got a PSA test, it's been a couple of years ago. It was at 10, and then I went to the VA and had another physical, and then they told me it was at 37.
All right.
That's when VA started the process.
So you got a PSA 10 years ago of 10,
No, not 10 years ago. It was just
2 years ago,
about a year ago.
about a year ago. Okay. And it was 10, but you just came back a year later for another PSA. Is that how it happened?
Yes.
Okay. Might have been nice if that 10 woke them up a little bit back then.
Well, what
Um,
happened was that was through Kaiser, and they didn't say anything. They didn't do anything. That's when I went to the VA. I went to the VA and had it checked, and when it went up, they went on and started the biopsy process.
all right. Well, it's a good thing you did. If you do decide to come back to this group in the future, would you maybe dig up your biopsy report for us?
I can do that.
Okay. So somehow, which I can't figure out, you got a lymph node biopsy which had prostate cancer in it.
I
Maybe
can't.
a PSMA scan, John. Did they do a PSMA scan after
I did.
before they?
Yes, I did. I did do a scan. Yeah, I
Yeah.
did a scan.
Oh, Rick figured it out. Okay. So you had a positive lymph node. And did you get any other scans or tests at the time of diagnosis or since?
No, I haven't.
Okay. So this speck, even though it's a tiny speck, appears to have spread to a lymph node. Was the lymph node in your pelvis, down near where the prostate is, or someplace else in your body?
It was down. It was down around my pelvic area.
Okay. Okay. So by this time you're switching over to the VA. They recognize that you have prostate cancer with an elevated PSA and a positive lymph node. Some treatment was already started, I assume.
Yes.
What are you taking?
I took a shot, and then I'm on 3 different medications.
What
Uh,
are they?
Abratrone,
Okay, abiraterone.
right, and prednisone.
When I first started out, I was like, all these names started flying by. I finally had to make a list of them, you know. So
Right.
abiraterone, prednisone. How much prednisone, by the way?
2.5
Twice a day?
once a day.
2.5 once a day.
Once a day.
We've been having big arguments about the proper prednisone dose. That's why I asked. And what else?
Wait a minute. No, it's a 5 milligram. 5 milligram.
Okay.
And then I'm taking a calcium
Why are you taking calcium?
because of the bones. The
Okay.
doctor said it would be better if I take the calcium.
Okay. Vitamin D also, or just the calcium?
Just the calcium.
But your bones were all perfectly fine on your scan, right? The
Yes.
doctor's just doing this just in case. Okay.
Yes.
And how many weeks so far now? So abiraterone, prednisone, calcium. There's another one, right, or no?
I took the shot, the Eligard,
Eligard. Okay, Eligard. How long ago was your first Eligard shot?
the 29th of October.
Oh, just a couple weeks. Okay.
Yes.
And was it a 6-month Eligard or a 4-month or
Every 3 months.
3 months? Okay. All right. Very good. And is it affecting you in any way yet?
No, it haven't affected me in any kind of way.
Okay. And who's your treatment team now?
Dr. Stephen Krasnow at the VA.
Kind of doctor is it? A urologist?
Oncologist.
Oh, an oncologist. Okay.
Mhm.
Do you know if this is an oncologist that specializes in prostate or a general oncologist?
I think he specialized in it. He did say something that he works. That's all he works on a lot is cancer patients.
But what about prostate cancer patients?
Yeah, prostate. He works on a lot of prostate cancer too. Yeah.
All right, we'll look him up and see whether he's a subspecialist or not.
Right.
Okay. What else? Anything? Oh, family history. Any family history of cancer?
I had an uncle. He had it, and I just found out tonight that one of my cousins, my first cousins, he had it. He had it in his blood, and he said he's cured from it now. Well, not cured, but he don't. It's not bothering him anymore.
Some kind of blood cancer, you mean?
Yes.
Like leukemia or
He just said
lymphoma, myeloma?
it was in his prostate and it moved to his blood.
Oh, I see. I
Yeah.
see. Metastatic prostate cancer. Okay.
Mhm.
And it might be good to get some genetic tests. Have you had a cheek swab or any kind of genetic test to see if there's anything running in the family?
No, I haven't.
Okay.
Okay.
That John, that would suggest to me that Dr. Krasnow is not a GU medical oncologist because the VA is very good about ordering the genetic tests. It's
Yeah.
very much part of their protocol.
Okay. Well,
So
that's probably one of the first things we're going to suggest then is that you get a test to see whether you have inherited any genes that make you vulnerable, particularly to prostate cancer.
yeah, is the cousin who had the cancer in his blood? Is that the son of your uncle who
Uh,
had prostate cancer?
yes.
Yeah.
No, he's not the son of my uncle that had the cancer. He's his father was my uncle's that had the cancer. That was his brother.
Okay, so you had an uncle who had the cancer, and then another
First,
uncle whose son had the cancer.
yes, yes.
Right.
All on
And
your
any
father's side,
right.
right?
What was that?
All on your father's side?
On my mother's side.
Oh,
On your
both of
mother's.
them on your mother's side, the uncle and the cousin?
Yes.
Okay.
And any other cancers in that side of the family? Did anybody have breast cancer or pancreatic cancer or anything like that?
I had my aunt on my mother's sister. She had pancreatic cancer,
Okay.
which she died from.
Okay. Well, we definitely, there are two. Sorry, John, go ahead and I'll come in after.
Well, I don't know, it's probably what Rick was going to say anyway, but just the fact that you have metastatic prostate cancer is enough to get genetic tests, but the fact that you have a positive family history even strengthens it further. Now, there's a couple ways to do it. You can ask your doctor at the VA to order a genetic test, or you can do it on your own for free through a study called PROMISE. And we will put a link in the chat box for you, which is if you go to the upper right of your screen, there's two little overlapping squares with a number 2 next to it.
Got it.
That's our chat. We have an ongoing conversation parallel to the group that goes on in there. We'll put a link to the PROMISE study through AnCan. They will contact you and send you a kit and examine the genes for you.
Okay.
There's
Now, just let me just interrupt here, John, because the other thing that happens at the VA is that they can send away that sample that they took from your lymph node and get it analyzed. And they should do that. Again, the VA is pretty good about doing that. If they find metastatic prostate cancer, they are good about getting it somatically tested. You may have to ask Dr. Krasnow or go into the link and have them follow through. I think, Jim Marshall, if I'm wrong about that, please jump in and correct me. But there's been a lot of work done in the background to try and make sure that the veterans get state-of-the-art care in prostate cancer. A lot of it's been done by Veterans Prostate Cancer Awareness and Mike Crosby. And so when you reach out to them through the portal and tell them you want that lymph node sample analyzed for somatic, SOMATIC. Again, I'll put it in the chat window, somatic testing. At the same time, you can do the PROMISE study, which is to check if you've inherited anything. And I'm about to put that link in, and that will just come to you through the mail. And you'll do a cheek swab and you'll send it back. It is a test that's being conducted by Johns Hopkins, who you're familiar with, and also University of Washington. It's a clinical trial, but there's nothing more you have to do. They're just trying to get a very large sample to see how prevalent inherited mutations are. But more than that, for you, you want a somatic test to see if you're carrying any special types of mutations, and you should be able to get that quite easily through the VA. We like to see it go to Foundation Medicine or Tempus, but I don't know enough about the VA to know where they're sending it. I think they send it to either Tempus or FMI, but I'm not certain. But don't worry your head about that one.
Okay.
Did you understand that difference between somatic tests and germline tests? Should I explain it again? Because it's an important concept and it went by really fast there.
Yeah, explain it again. Let me hear it again.
Okay. Every cell in our body has genes in it. Those are inherited from our parents, half from each parent. Sometimes those inheritable genes mutate or change. And some of those mutations make us more vulnerable to prostate cancer. So that's why we want to know if you inherited anything from the maternal side of your family. That would be in every cell of your body and can get it with a cheek swab, for example.
Okay.
Now, in addition, the cancer cells themselves also mutate. Some of those mutations in the cancer cells damage the cell's ability to keep itself protected and safe from abnormal growth, which is why it turns into cancer. We call those kinds of cells somatic cells, and those kinds of mutations somatic mutations. That we can only test for by getting the actual cancer tissue itself. Both will help your doctor guide your treatment plan.
Okay. Okay. Well explained.
Now tell us, first of all, do you have any symptoms of any sort of your prostate cancer?
I don't have any symptoms.
Okay. And do you have any questions?
Uh, not at this time. I don't.
Okay. Now, as the weeks go by, you may start feeling some effect of your Eligard. You may even start getting some side effects of your abiraterone. You should monitor your blood pressure. Let your doc know if there's any swelling anywhere. And if you'd continue with our group, we'll be able to tell you the whole course of treatment with that Eligard. You're probably going to be on it for 18 months, maybe even 2 years. And the side effects alter the longer you've been on it. And there's tons of experience because almost everybody, or maybe everybody in this group, has been on a drug like Eligard, and we're very familiar.
Okay.
Now I'm gonna just open this up to anybody that would like to share or contribute. All of us have been in James's position in the past. You want to start, Rick, because you got your hand up?
Yeah. One thing that you should be discussing with your medical oncologist, first of all, we really need to find out if this guy is a specialized prostate cancer medical oncologist. It's really important because if he isn't, you have the ability at the VA to switch and find a specialized genitourinary medical oncologist outside of the VA. And we would strongly recommend you do that for a bunch of reasons to make sure you're getting the right treatment. In that regard, we also have a veterans group, which is led by Captain Jim Marshall, who's got his camera off right now because he's having internet problems. But Captain Jim leads that group twice a month, which takes me to the next thing, which is, do we have your email address?
I did type it in. Yes, I put my name and email address in.
Okay, well, we'll look for it, but do me a favor, for good order's sake, type it in again on the chat when we're done speaking.
Okay.
After we're done. And we will make sure you get a reminder, not just for this meeting, which happens every week, but for the veterans meeting, because we want to make sure you're getting all the benefits that you're entitled to at the VA. And that's Captain Jim's expertise. And we want to make sure you're getting the best possible treatment you're entitled to at the VA, which is also something that Captain Jim is really good at, and all the other vets, because they've learned.
Okay.
One thing that occurs to me that probably hasn't been discussed with you is whether they should be radiating anything for you, and especially the prostate. Because in the old days, we never treated the prostate when we found men who were immediately metastatic. Today, we think it does help. And the doctor that you have at the VA, if he's not a prostate cancer specialist, will think, oh, we never We never treat the prostate when you're metastatic, but that isn't the case anymore.
Okay.
The
Okay.
doctors we send you to might say, yes, it's a good idea to get that prostate treated because it inhibits, it slows down the spread. So those are a couple of things. Did you want me to repeat anything, or you think you got all that down?
I think I got it. Let me say this. What you just said is that it's a possibility that I should be treating the prostate with radiation as of like right now, or
Yeah,
right now.
yeah.
Yeah, they usually do it within about 6 months of diagnosis. Doesn't have to be right now, but they do it fairly quickly up front. It's a good idea to do it up front. Yes, go ahead.
Okay.
That's what I had. I started out like you with spread to the lymph nodes, and I got radiation to the where my prostate was before my surgery, and also the whole pelvic area, because there's quite a few lymph nodes in there, and a number of them drain from the prostate, so they pick up the cancers quite readily.
Yeah, well,
Well,
that's the second. Go ahead.
how soon after you found out
Okay.
that you had it that you got radiation?
Well, you
So,
could do something like a couple of months of hormone therapy to maybe shrink the cancer a little bit. Some people believe that it sort of softens up the cancer cells so that radiation can kill them, and then get started. Rick, another different opinion?
well, yes, we're talking about two different things here. John, I was going to come to what John is talking about. There are two different areas that we need to consider radiating. One of them is the pelvis where the lymph nodes are. And has that been discussed with you? Any radiation in the future?
No, not
Okay.
yet.
So it should have been again, which again makes me think this guy is not really a prostate cancer doc. The second thing is what I started with originally, which is the prostate itself. They may also want to treat. They can do it at the same time as the radiation across the pelvis, or they can do the radiation across the pelvis first and do the radiation to the prostate later, but both of them should be considered.
Okay.
And you should be raising this with your team and it will help set us up, I believe, to make a transition to a prostate cancer medical oncologist easier. Jim Marshall, is that right? I mean, if this guy is not a prostate cancer medical oncologist, what do we do? How can we move Jim across?
Yeah, well, I would think so. There's a thing called community care that can uh, move you out of the VA and get you to a specialist. Although that has to be approved. So I believe it would be.
By the
Is it,
VA, approved by the VA.
Yes. And in fact, I am right now pursuing the same thing, starting to.
Jim, is community care what they called fee basis in my day?
Might be. I believe community care name is changed again, but it's still called community care.
Okay.
It's a voucher that you get good for a year.
Yeah, I think it is, Dr. John. I think that since you left the VA, they've now created this community care program in response to the shortages of doctors at the VA, and
Now,
they call it community care. And if there isn't a doctor available in your area, in your VA, then you can go outside the VA under this community care program. So this is really what, we'd like to drive you to the point of getting the best possible care through the VA. And I believe we can do that.
Mhm.
And we'll navigate you the right way to get to that point. Right now, you're doing great. I mean, another thing that tells me this guy is not a prostate cancer doc is that he put you on Eligard rather than a pill called Orgovix, because Orgovix is immediately available as a pill at the VA. They're actually, it seems to be the preferred drug right now, as opposed to Eligard or Lupron, which is the old-fashioned way. And so I'm kind of surprised. Which VA, this is more for Jim Marshall's benefit than for mine, because it won't mean much to me, but it will to Jim. Which VA are you using?
The one in D.C., Washington.
Okay.
Right.
Okay.
Right now, my next appointment for that Eligard is January the 28th.
Right.
Should I pursue that a bit earlier and just go up to the VA and find out who I'm dealing with? This guy, because I want to know who this guy is.
Well, you don't need to get the shot any earlier, although you could let them know that you don't want the shot after that. You want to go on Orgovix, and I'll put that in the chat window for you.
Okay.
But you do need to pursue as quickly as you can and find out, or it's possible to, Captain Jim, can you find out anything about this this Dr. Kresno
I will try, yes.
at the Washington VA? Is it spelt with a K or a C, Jim?
It's KRASNOW.
Okay, well,
I need to find out too, because I happen to need him if he is a Genito. Or
well,
if he isn't, then I
I
want to
got
know.
I got him here.
I wouldn't be so quick, to be honest, because I'm not sure why he put Jim Thompson on, gave him Eligard and didn't give him Orgovix. He hasn't talked to him about radiation therapy. Right. There's a bunch of other things. So if he thinks he is a GU Medonc, he may not be our preferred one.
Well, absolutely.
Okay. Excuse me.
I got a picture of him right here. He calls himself a urologic oncologist.
He's a surgeon.
So he started out as a urologist.
He's a surgeon.
I think, since you have metastatic disease, we would like you to see a genitourinary prostate cancer specialist oncologist.
Yeah.
Okay.
That's the problem. He's a surgeon. He's not a medical oncologist.
Oh, okay. His first name is Stephen, right?
Let's see if I got the right guy here.
Stephen.
Yeah, that's what I just saw too, Stephen.
Yeah. So to cut to the chase, because we've got to keep moving along here. You're seeing a urologist. You don't want to be seeing a urologist. That's why you're not getting the best care, because you're already metastatic. And Captain Jim, we got to help Jim Thompson move along to a GU Medonc. Okay.
Okay.
I had the wrong first name. That was another Dr. Krasno in Washington. Stephen Krasno is a general oncologist.
Okay, he's a general oncologist. Same difference. Yeah. All right. But if he's a general oncologist, which is what when you said he was a medical oncologist, it struck me that he's probably a generalist and not a prostate cancer guy from all these things. We got to get you to a prostate cancer guy, Jim Thompson.
Yeah, that's where I want to be.
Okay, so we've got one question, Dr. John, then we should move on. And then after that, please be sure to put your email in the chat window for me, Jim.
Okay.
Dennis, and then Len.
James, I had one quick question for you. I think if it was me and my doctor told me I had a speck on my prostate, I think I'd want something a little more definitive. Was that determined by the PSMA PET CT scan?
Uh, uh,
Said it was a scan that they did? Do
they
you
did,
know?
they did a scan. They did a biopsy, and then they did a scan. And
Biopsy the lymph node.
they
They
did
did
a
not
biopsy
have,
on my they did a biopsy on my prostate first.
oh, they did do a biopsy on the prostate.
Right. And then they did a scan. And then they did another biopsy on my lymph nodes.
Dennis, he's gonna bring those biopsy reports, and you can actually send them either to me or to Rick if you want us to look them over, but we will need them to discuss with you. I mean, we don't know your Gleason score or anything like that yet.
Mm-hmm.
Is that what you meant, Dennis?
Yes, I was concerned that the spec description
Mm,
was not better defined. If it was a PSMA PET CT, they would have an uptake number
yeah.
for that, which really would describe how large it is. Uh,
Did they do an MRI before they did the biopsy,
No,
Jim
they did.
Thompson?
It
No, they
They
sure
did
did.
sounds
not.
like no. Yeah.
No. So again, that's just not standard of care anymore. I don't know what they're doing.
How about Len? Did you have something to add?
Yeah, Jim, you said you're not having any side effects yet. You just recently started the hormone therapy, I believe, correct?
October the 29th.
Yeah, so it's likely that you will begin to experience some fatigue in the near future. The best way to combat that is with exercise. Do you exercise?
Yes, I have started. Yes.
Okay, good. Because even though it's almost counterintuitive, when you start feeling tired, you want to get out there and move, exercise, walk, lift weights, in moderation, but make sure you keep active. Um, and you feel you have a good diet, like a Mediterranean diet?
Uh, well, I'm be working on it anyway.
Working on it. Good. All right.
Since then, I have changed. I've changed a few things.
Very good.
Yeah.
More fruits, more vegetables.
Yes.
Good.
Not steak every day.
No.
Occasional steak, okay, but not frequently.
Trying to get away from it.
All right. Well, we're glad to have you come back if you want. And I think, I'm not sure, but I might have heard a soft female voice in the background there. If you have a spouse that would like to sit in, she's perfectly welcome.
Okay. Yeah, she was here taking notes for me and everything.
Yeah, she
Right.
she can join right in on camera if she wants to.
Okay.
Excuse me, gentlemen. How do I raise my hand? I'd like to speak in turn.
There's a little button at the bottom called React or Raise My Hand. Who is this?
He's a
Doug,
new guy.
Doug,
He wants
there
some time.
Okay. All right. There.
Oh, okay.
Got it. Thank you.
Okay. All right. Let's see. That's gonna
Okay.
throw my timing off. I think.
I'm afraid, Doug, are you new to the group?
Yes.
And are you signed up? Are you receiving our reminders?
I just signed up. I talked with Rick. He invited me about a week ago.
Okay, I'm Rick. Well,
Yeah.
and we spoke last. Okay,
Yeah. I'm the guy with the intraductal cribriform.
Okay, I think that was some time ago. Here's the problem. For new men who come in, we need you to be here in the first 10 minutes.
Right.
Okay? Because we figure out all of our timing. So what I would suggest you do is please come back next week so we can spend 30 odd minutes with you to go through your whole history.
Okay.
Because we can't do that today. Now, Len, who you can see on the screen, or maybe not because you're on the telephone, but Len will be in charge, and we'll know, and we'll give you priority, and we'll talk to you first.
Okay, sir.
But we can't, unfortunately, we can't give you a fair shake at this point today as a new man.
Okay.
If I have time at the end, Doug, I'll swing around and we can get started and then just pass the information on
Okay.
to Len. Just for introductions, I'm John. I'm one of the moderators. Rick, who you've been hearing, has the white background there. He's the founder and head of AnCan. And Len Sierra is one of the moderators as well, knows a heck of a lot, backs us up scientifically, and runs his own group. And you'll see him on Monday. What's your last name, Doug, if you don't mind giving? If you do, you don't have to.
It's Bent, B-E-N-T.
Okay. How old are you?
I'm 69.
Okay. Okay. If there's time at the end, I'll get to you. Otherwise, Len will get to you.
All right.
Let me go to Bill, Minnesota Bill. See what you got on your mind. I can't hear you, Bill. Unmute yourself.
All right.
There you go.
Sorry. All right. Just a quick update. I got my Decipher score
Oh,
back. It's 0.54. Relayed that to my doctor, my radiation oncologist. He said that I could cut my hormone therapy course from a year down to 6 months based on that. I'm taking Orgovix. I'm about 6 weeks into that.
okay. Well, that's good. That's good.
And second thing is, I was lucky enough to get a grant for Orgovix from Patient Advocate Foundation through my pharmacy. Tremendous customer service there.
Can you tell us a little bit more about how you accomplished that so those of us without insurance would know?
Sure. Just this tremendous specialty pharmacy in my area here in Minneapolis. And they automatically assign oncology patients a patient advocate who is a pharmacy tech. And they're versed in the various grant programs, and they track when grant openings occur, and they will submit names of eligible patients. And so I had a fantastic advocate who was right on top of when a grant opened with this particular group, Patient Advocate Foundation, and she submitted it. I had to submit some documentation. It involved income levels. Okay. And about 2 weeks later, I got an email and a call from my pharmacy tech that I'd been awarded this grant. I was just like winning the lottery.
That's fantastic.
Yeah.
We are happier to have you on Orgovix than the stuff that the rest of us took.
Yeah, I learned that thanks to this group that was the preferred way, and I talked to my radiation oncologist up front about that, and he said, "Yeah, if you can get authorization, which seemed to be no problem with that." The third thing I was going to mention, initially, my Medicare Advantage plan denied coverage for my radiation therapy. I had wanted to get proton beam therapy, and I hope I don't come off as a proselytizer here. I'm not. It's just the route I wanted to investigate. But anyway, my oncologist team submitted an appeal for me, and they won.
Wow.
So they're
Great.
going to cover the whole thing, my insurance company. So
Now, I had a note that says needs a good radiation oncologist. So do you have a?
yes, it's
Okay.
after the denial. That's when I was looking for an alternative, and Rick had recommended go to Masonic at the University of Minnesota.
Okay.
And I had contacted them, but then this all worked out. So my RO is Dr. Carl Rossi, ROSSI in California. San Diego clinic is called California Protons.
Okay.
So here's the thing, though. The downside of this is that you're going to finish up doing 40 odd sessions instead of 25 sessions.
Oh,
40.
28. 28.
So you're going to do 28 sessions. So is he giving you the proton with is he doing proton SBRT then?
No, he ran a select group. I'm not sure the time frame, a year or 2 years ago, uh, checking SBRT. Okay, and he came away with results saying that side effects were too high for proton beam with SBRT. Now I know other facilities do SBRT with proton, but he quit at that point after that.
Okay, but here's my concern, and
Yes,
it's a big concern, Bill.
thank you.
That 28 treatments, if he's only using regular proton, is not enough because he can't be treating the gland and the pelvis and across the pelvis. So he's either just doing the prostate bed and the prostate at this point, or I shouldn't say either. He must only be doing, and I think you've got to talk to him. And if it were me, I would be wanting what we told you, which is the really the gold standard in your situation, um, which is SBRT plus IMRT plus hormone therapy. In other words, treating the gland across the pelvis and the hormone therapy. So you need to find out what Dr. Rossi is going to give you. What did they? How did they stage you? Did they stage you as a T2 or a T3?
T3B.
T3B. So if you're T3B,
Excuse me. My urologist staged me at T3A. Dr. Rossi, and this is after the PSMA PET scan, okay, staged me at, he said, either T2B or T2C. Okay, so, and here's his treatment plan is
yeah.
28 sessions through the prostate and the pelvic nodes, and I have one on the PSMA. There was one aortocaval node that had slight uptake, but it's less than 2, which is, Dr. Rossi said that's below the level we would consider malignant, but we will still treat that. So that's also going to be treated in these 28 sessions. Now, they will vary the intensity on the prostate so that the tumor area gets a boost, higher gray level.
Right.
So I could give you the gray levels. He broke it all
No,
down.
it's not the gray levels, but if he's not using SBRT, then what concerns me, I think what you need to ask him a couple of things. The first is he treating all the pelvic nodes right the way across your hips, right
Yeah.
away across your pelvic girdle?
Yes, he is.
Okay. I my concern is I've never heard this done in 28 sessions. We've known a bunch of people who have gone to Rossi before, but to
Sure.
do all of that in 28 sessions when he doesn't use SBRT just doesn't sound right. I mean, normally you'll get 4 to 5 sessions SBRT and then another 20 plus sessions with IMRT. And that's where you come up with about 28. What he's doing is the same equivalent, although he says he's increasing, but he doesn't use SBRT, but he's increasing the dose. I'm suspicious. I mean, the
Yeah.
other thing is, I'm also concerned that he's decided to treat you as if you were T2B, and yet you were originally staged as T3B. That's a big difference. That's a huge difference.
Excuse me. Initially staged at T3A.
Okay,
By
T3. Even so,
okay.
to go from T3. I mean, I was a T3A. To go from T3A to T2B also significantly impacts the length of time that you are going to be doing hormone therapy. And if you were T3A, you would be doing hormone therapy for at least 18 months, whatever your decipher said. Your decipher, frankly, is irrelevant if you're a T3A. If you're a T2B, yes, it's very relevant. Now, what we don't want to see is that you get this treatment and you come off hormone therapy in 6 months. And then, like too many of these gents who come into this group, the disease comes back.
Sure.
Right? We don't want that. And as much as you want your proton beam treatment in Southern California, I just, if it were me, I would be very, very skeptical. And I would want a second opinion. I'd want somebody else to look at all those scans. I'd want them to confirm that you were T2B and not T3A. And I'd want them to approve that treatment process before I started it. That's the only thing we can say. I mean, that would be our concern, because we don't want to see you back here in 9 months to a year. I mean, hopefully we'll support you during the treatment, but we don't want to see you back in a year saying, "Oh my gosh, the disease is back." Anybody else want to comment on this, and then we'll go back to Bill to clear it up.
I don't think so.
Okay, go ahead, Bill.
Well, I will follow up certainly with Dr. Rossi, and I can get another opinion. You know, probably X-ray type radiation, and see. I can check too whether SBRT would be recommended. Um, so, but Dr. Rossi said, his staging, he would say T2B or T2C. And I think the question there revolves around that one aortocaval node that showed the slight uptake.
I
He
don't think
says,
so, Bill, because if that
okay,
was actually known prostate cancer, you'd be stage 4, wouldn't you?
that's my understanding, but I'm just an engineer, so I'm not.
Well, I think you owe it to yourself. You are at you're in Minneapolis. Who have you been getting your treatment from in Minneapolis?
A local urology specialty clinic, Minnesota Urology, um, who seems to be okay. Although they apparently, I had to have 2 biopsies before they got a positive, and it seems like it was there. The cancer was there on the first biopsy, but they didn't get it. And I discussed that too. It was an anterior lesion, and they did a transrectal biopsy. And I know it can be fairly difficult
Yeah,
to
it
get.
can be. But I mean, again, the issue here is I am concerned about Dr. Rossi. Dr. Rossi has his own way of doing things.
Okay,
We go a long way back with people who have been treated by Dr. Rossi. And there are people who come in regularly to the low intermediate group who are Dr. Rossi patients. Okay.
okay,
Also, the radiation oncologists who treat with proton beam do things in a different way. And I would strongly, strongly encourage you to get a second opinion from a radiation oncologist on your staging and since you have the plan, on that treatment plan. And you can
okay.
do that from a RO at Masonic. If I have a name, I'll look in a minute. I'll give it you, but I can't think of I don't know the ROs like I know the GU medoncs.
Yeah,
Uh,
I through the Masonic website, I requested an appointment. It's been a few weeks ago. Dr. Chin Soo Cho, uh, radiation onc, um, but I never heard back, and I found that a little disconcerting. But I can certainly follow up with them. I think obviously I need to call them, and um, they do have a bit of a reputation over there for kind of goofiness in their scheduling department.
in their what department?
Scheduling.
Oh, okay.
So I
Um,
think somehow my request just went in the bit bucket. So as they
yeah.
say.
Um, I'm just looking right now to see if I can get a list of their practitioners in there, and I'll put it in the chat window because I don't want to hold up because I know
Thank
John's
you.
got a lot to get done. But please, please, before you start treating, when are you scheduled to go out to San Diego?
Uh, my first visit is right after Thanksgiving for the space sore. I have a consult regarding the space sore this coming Monday.
Oh, they use that for proton therapy as well, huh? I didn't know
Some
that.
practitioners use it, some don't, but
Oh,
they do.
I see.
Okay, I'm looking, and to be honest, I don't recognize any of these names. I see the guy that you've reached out to. You need to. He's probably the guy who they identify as doing the most amount of prostate. That's probably why you chose him. I'm guessing.
Yes,
Yeah. So
lots of experience too.
right. So
Yeah.
just go back to him, find him, or push comes to shove, go to Minnesota Oncology and speak to their guy who does the most amount of RO for the second opinion.
Okay.
I would not be going out until you had a very solid second opinion. Don't launch yourself into this process until you've got that good second opinion, Bill. That would be our best advice.
Okay. I
Quick
appreciate
question.
it.
Quick question before I let you go, Bill. Was your promise test all negative?
I haven't received the results yet on
Oh,
the
still
promise.
okay. Okay. Very
But
good.
I did have a prior test.
Yeah,
Uh,
which was negative. Yeah.
yeah, yeah.
Yeah, very good. Okay, we'll be looking forward to
Thanks,
catching
guys.
up with you soon.
Appreciate it.
Uh, let's see. I got no hands up, so I'll go on to Bill Lee. Bill Lee, could you unmute and let us know
I
what's on your mind? Hi.
just like, yeah,
We got to see there.
there we
Now
go.
we see you. There. Now we see you, Mr. Lee.
Hitting too many buttons.
There you
Just an update since I hadn't been here since September. Um, last I think I told this group was the cystoscopy had noticed they did find a stone, they said. And then it turned out, no, it's not a stone, but it was a surgical clip from the prostatectomy from 4 years ago.
yeah. Oh, yeah.
And so had surgery, went in there, they got it. And I feel fantastic. Just have the stress incontinence is kicked in again, though, obviously from them going in and getting the clip out of there. But hopefully that will tighten up shortly.
So if you cough or laugh or get up out of a chair, you'll leak?
Oh yeah,
Yeah, okay.
yep. Even worse is I play bagpipes. Like I wear
No
go.
kidding.
have to wear Depends.
That's the first AnCan bagpiper I've heard of. Rick, have you got anything
No,
more?
we knew that already.
Okay.
I just want to tell you, Bill Lee, that our Alexa, was at a what do you call a Highland gathering? What do you call that?
Yep,
Yeah,
Highland.
and with her McTavish clan, and she won a 10-year-old bottle of scotch. She sent me a picture. So that was this past weekend. So God bless her.
This sounds familiar. I guess I did hear this. Anything else for Bill or from Bill?
Nope. If anyone else has had a prostatectomy and radiation, and the doctor just keeps saying, "Oh, your symptoms are radiation," yeah, may want to dig a little deeper.
Oh yeah. I mean I have a urologist. I have cystitis and all, and the one doctor blames the radiation doctor. The radiation doctor blames the surgeon, and you know, you just got to keep looking till you figure it out. So it's a good thing you did.
Yep, so that's it.
The next guy I have on my list is Chuck.
I just wanted to give a little update on my Pluvicto treatment for, I've got the stage 4 cancer with mostly in my lymph nodes, abdominal lymph nodes. And at one point I had some metastases in my spine, but they seem to have gone away from all the treatment I've had. But I completed four out of the 6 Pluvicto treatments. And after the 4th treatment, PSA went undetectable, and I've been undetectable for 5 months. And then about a month ago, I had a blood test, and they found that the PSA had gone up to 0.72 from 0, or 0.05.
And that's about 4 months after your last Pluvicto, something like that?
5 months.
5 months after your last Pluvicto.
Right.
Okay.
So
disappointing.
Sorry, what was the level, Chuck?
0.72.
Thank you.
Yep. 0.72. My PSA has always been very low. It's never been above 35. So he's concerned. My oncologist is concerned when it, even a small increase could be a problem. And it turned out it was, because I had a PSMA PET scan and showed some of the lymph nodes had shrunk, but some there were new lymph nodes that increased in size. And then they found a spot on my right rib lesion, and on my left lung, it was a dark spot. They couldn't make the conclusion if it was a metastasis or what, but it was just a dark spot. So it could be just benign. We don't know yet. But anyway, so I'm back on the Pluvicto. I completed round number 5 last Monday. So it's been a week, and I'm finally getting over my nausea. I usually have a week of nausea, but I've been taking Zofran, but it's a battle between nausea and headaches from the Zofran. So,
Oh,
yeah, it gives me bad headaches, but I'm glad I'm over the nausea. So the next question is after I complete these 6 rounds of Pluvicto, what's the next step? And I talked to my oncologist about that, and he mentioned, well, the clinical studies only involved 6 rounds of Pluvicto. And another thing and I said, well, can I continue with a Pluvicto? And he said he was concerned about my blood, my neutrophil level, because they hadn't really recovered, over the 5 months. They were still below the minimum, and if that's too low, that disqualifies me from, additional Pluvicto treatments. So he did mention a clinical study that's going on at NYU, a Janssen trial. I'm not sure if anybody's heard of it. It's a bispecific antibody immunotherapy trial. So that's another possibility for me, to get on that trial. So, but that's the update. Just hoping that the Pluvicto will continue to work for me.
The white blood cell count, do you happen to remember the neutrophil count or the absolute or any?
Yeah, it was the absolute. It was 1.5, I believe.
Oh, yeah, right on the very margin. That might disqualify you from a immunotherapy trial too. Who knows?
Yeah, that's what he mentioned.
Yeah.
Actually, it's not 1.7. 1.7. 1.5 is the minimum.
Yeah. Okay. That's a little better. Rick, did you have a comment?
Yeah, I had a few comments here. The first thing is, before they put you back on the Pluvicto and they did the PSMA scan, did they also do an FDG PET?
They did not. No. I actually asked him about that, the oncologist, and he said that they can detect any, if there's any lesions or tumors growing, they can detect that with the CT, the CT part of the scan. So he didn't seem to be very concerned.
I don't think so. I don't think so, because that CT part of the scan is basically for location. In other words, what they do is that they need to locate, the PSMA doesn't locate where on the anatomy those lesions are. So they're doing that CT scan to help them locate on the anatomy, so they know that that spot was on the rib, or it was in the left lung, or wherever it is. This is the first I've ever heard, maybe the other guys have, that they say, well, no, that's the CT scan. You have unusual disease.
Yeah.
We need to be ruling out that you are not now showing disease which is not PSMA sensitive. And you need to go back to WISE and say, I want an FDG PET and I want it compared. Never mind what you think the CT is. I want that peace of mind, because I'm concerned my disease could be morphing. and you tell him what your disease is, and then let him tell you to prove that it's not. Because here he is submitting you to more Pluvicto, and we don't know to what extent you're PSMA. Well, you obviously are PSMA sensitive because he did another PSMA scan, but there may be stuff that is causing issues which we're not aware of. I'm not saying you don't have PSMA sensitive prostate cancer where the Pluvicto can help you, but we got to start looking at what else is going on. Is the bispecific that he's talking about PSMA sensitive? I think it is. If it's the Johnson and Johnson one, I think it is. Did he tell you what the how it works, the bispecific, what it's attracted to and what it carries?
He didn't give me any details. He just said it was not Johnson, a Janssen. He said Janssen trial.
Yeah, well, it's not Janssen. Yeah, it's not Janssen anymore. It's J&J. They've actually abandoned Janssen this year.
Okay.
So it's Janssen, but it's a J&J trial.
Okay.
I mean, I can find out quite a bit. It's been around a while. Len, do you remember what the J&J bispecific is that they're testing? I think.
I do not. It wouldn't be the steep one, would it?
Oh, I wonder if it was. I don't know. I need to look, but that's why I want to know what it's being attracted to, Chuck, and converse with him and find out. That's the first thing. Second thing, have you tried using ginger in any form for your nausea?
Yeah, I have. My wife is a big advocate. She can actually take a piece of ginger and chew on it, but
yeah,
to me that's just too strong and
okay. Try. Look, first of all, you may have seen this. I think we put it in the reminder last week or the week before, but there is an explanation why ginger works, because it intercepts it affects the receptors in the brain that sense nausea. The ginger does that. So
yeah.
it has I'm just looking here. Forgive me for a second. I just got to put my light on. But bioactive compounds in ginger block the pathways which stops the vomiting center in the brain from being switched on. So there's a real reason. And one thing they suggest is taking an inch of sliced ginger, steeping it in water, hot boiling water, adding a little bit of orange juice and a drizzle of honey, and that it might just help you. It won't be so strong.
Right.
And just saying, if you've been having these nausea things and you're going to go through it again, try it. It's not going to hurt you, right?
Yeah, right.
And you may come on and say, "Ooh, that ginger stuff was the best thing I ever heard." So we don't know, but
Jim Marshall just asked if ginger snaps would work. You probably would have to eat the whole box. I don't know.
yeah, you'd need some very strong ginger snaps. But I'll tell you what do work: that ginger candy that you buy at Trader Joe's in sort of that light green, wrapped in that light green wrapper. Those ginger candies do work because I know people who have used them.
All right.
I'll try that.
Suggestion. So the ginger. So those are. My concern is we've got to start ruling out that there's not something else going on with your weird disease, and you need to put that up fairly and squarely in front of David Wise, and see what he says about that and how he wants to address it.
All right.
If ginger doesn't work, your Zofran, there's a sister drug very much like it, which is called granisetron, and it might work It can also cause headaches. It does in a number of people. It's used for chemotherapy-induced nausea. But even though it's in the same drug class, it doesn't necessarily mean it will cause a headache, so it might be worth a try. And there's other drugs for nausea, phenothiazines. I don't know. I think they're kind of unpleasant. Some of the other ones, sedating and brain fog. I don't know. Len, do you have any suggestions for nausea besides ondansetron?
Nothing other than what you've already mentioned, and of course, THC is supposed to be
Yeah,
helpful.
and
Yeah,
acupuncture.
Yeah.
yeah, I do take THC, CBD and THC oil every night. It helps me sleep. But
Hmm. Hmm.
yeah,
The other thing I think I would be doing is I'd be getting somebody from the palliative care team, palliative care on my team from Langone.
Yeah, good
You,
idea.
do you have a palliative care person yet on your team?
yeah, you mentioned that several times, but I haven't really looked into that.
Okay.
But I think I'll do that. Yeah,
You've got to do it because palliative care means symptom management. And symptom management is a lot more knowledge than Dr. Wise has about nausea. It
yeah,
brings in some of the things that Dr. John is saying because he's worked with nausea for many years. And, if Dr. Wise is reluctant, come back and talk to me. We've got a back door that we can use at Langone, but I don't
okay,
want to go there because he may be very receptive indeed to and people are putting suggestions in the chat box too for natural suggestions.
Yeah.
So please don't suffer. We don't want you to suffer, and I think the palliative care team is going to be a very good addition for you. Should be able to do it virtually with them too.
hmm. All right,
I
okay,
agree. Nausea is, I mean, for a symptom that's not dangerous, it's really awful.
yeah,
Nausea is awful. So try to
it
get
is.
rid of it.
Yep.
I'm going to move on to Michael Chandler. You had something to bring up tonight.
Aloha from Maui. I'm a
Aloha.
66-year-old guy who chose to get the alien removed out of my body uh, 31 months ago. And my PSA's been low, yada, yada, but it's been doubling every year. So that's been concerning. And now it's doubled in a 3-month period. And it was a wake up call. Because of you all, I chose to have all my care done at a center of excellence, the teaching hospital of UC San Diego Health. And their the urologist, Dr. Raina McKay there, she
Hmm.
says that I have all my scans for 3 days scheduled at the end of January. And we'll see her, and I'm going to meet a radiation doctor. And thank you for the email you sent this morning, Rick. Uh, Very useful. And so we're trying to get those moved up. And Cheryl, my number one health advocate, my wife, attachments that you shared, Rick. And so I got a fire under my feet.
Rick,
So
have you
you
got a good database on Mike?
Yes, I do, because
Okay.
we counseled Mike at length in um, 21 and 22.
Okay.
You probably don't remember. You were sort of going through treatment, but
Mhm.
so yes, I don't have a great database, but I have
Uh,
enough. Your PSA right now for Dr. John's purpose is at point two.
0.20.
Point
Uh,
two, yeah, 0.205 is what I had. Yeah. So I'm from memory because I forgot to put it in this morning. Um, you know, and just to confirm, because I wasn't sure, after you had the radical prostatectomy, You had all negative margins, right?
Correct.
Yeah.
Yes.
Yeah.
But
Cheryl.
you
Oh, look who's here. Oh, look who's here. Okay.
she's
I
butting
better,
in.
Come sit over here,
I,
Cheryl.
I better stand to attention, Miss Cheryl.
Come on.
You smarty pants. I'm just reminding him to tell
Yeah.
you because the bad part was he had cribriform and intraductal.
Yes.
So that's what makes him super high risk. And they, Dr. McKay said there's like a 50% chance it would come back, but it's just so weird that it's doubled in 3 months. So
Not really, because, once it gets a grip, it makes enough so that we suddenly see it. He was also 4+5, Dr. John. Michael was also 4+5.
Thank you.
So
Yeah.
great. I mean, it's not great to see you here, but it's great to see you. If you know what I mean.
I do know what you mean.
So
the other thing with him too, for some of these terms that some of you guys that have been here a while, so it was intraductal, tertiary 5, but it was negative on his margins and seminal vesicle. But we just think it's important to move up this pylarify. She was telling him not to really worry about it and get it done in January, but that could bring him up to 0.4. Can you imagine?
Well, I mean, whether we treat at 0.2 or we treat at 0.4 is probably not going to make a huge amount of difference. And it's quite possible we may not even see anything on this PSMA and we may have to do it again at 0.4. That could well be. Just because we don't see anything, it doesn't mean it's not there. A couple of things
Right. Well, your article, though, was really, really informative. And made the point that there's a big difference in getting it done at before 0.25 and after 0.25.
Well, we think there is, I mean, we tend to try to do it at the lower level. And there are people like Dr. D'Amico and Dr. Carroll and some of those other people who are on that article who want it done. But then we're always fighting with the insurance companies who don't want to approve it until you're higher and
Right.
My concern is we keep a very close eye on it. So when was the last time that 0.205 was? What date, Michael?
It was
October.
Yeah, end of October.
Okay, so
not too far.
Right. So I'd get another test, whatever happens at the end of. If it were me, I'd get a test at the end of November for sure, 30 days after. Let's keep a really, really close eye on it. And I don't think it hurts because if we don't see anything,
yeah, I'm gonna email Dr. Rana's nurse about the ctDNA that you mentioned. I'm gonna ask her about that. And then what do you think about the CT and the MRI? Do you think those are fine to wait, or do you think he should do those sooner as well?
I think the PSMA is really what I'm not. If it were me, I wouldn't be so worried about the MRI and I think that we're going to need a PSMA to see what's going on. To be honest, I don't think you're going to see too much. But let me talk about the ctDNA for the benefit of everybody that's on the group.
Okay, I'm going to listen.
Okay, and this is just this is a bit of a. I don't want to say it's an AnCan theory because I haven't talked it over with my other moderators, so we'll have to call it an RD theory right now. But I've been listening to presentations on ctDNA, and ctDNA is a little bit different from circulating tumor cells. It's smaller pieces of these tumor cells that have broken off from the tumor and are in the blood, okay? And they're using ctDNA now to see how effective treatment might be, much the way they're using CTC, but it's circulating tumor cell tests, but at a finer level. And there's a company, I think it's Intera, who's really pushing this ctDNA. Now, Dr. Mackay is going to know all about this, like a lot more, so much that we'd like to get her on and have her talk to us about it at some point. And it sort of came to me recently when Jeremy L was with us and trying to figure out how much radiation he should do. And my thought is that if you have micrometastasis and we're not exactly sure what's going on and where it is, that the ctDNA could be a good test to find out if in fact we're looking at some type of metastasis. Now, Dr. Mackay said, well, we already know that because the PSA is going up. Okay, well, then it is redundant. But it can also may guide where and how to radiate. And this ctDNA is still so early on that we don't really know what the use of it is yet. But I haven't spoken yet to any of the GU medocs to see if there's a use. But I think it's worth a discussion, especially with somebody who's on as far on the cutting edge as Dr. Ranner is. So I don't know, Len, and before we come back to Michael and Cheryl, Len and Dr. John and anybody else, do you have any thoughts on using ctDNA in a situation like Michael's?
Well, I guess nobody really knows how the best way to use it is. I think one of the things this reminds me of our discussion with Chuck is that ctDNA may turn out to be able to detect neuroendocrine transformation, which will be nice. Otherwise, I mean, cancer cells are turning over. They're shedding little pieces of DNA. They get mopped up rapidly, but the amount of ctDNA compared to regular DNA apparently tells a lot, both in terms of prediction of treatment and prognosis of the disease. But I don't think there's any guidelines for its use yet. Do you, Len?
Well, it's used in liquid biopsy, no?
Yeah.
Well, no, because in the liquid biopsy right now, they're using CTCs. At least FMI is using CTCs. They're catching the circulating tumor cells as opposed to the circulating tumor DNA. And the circulating tumor cells are then broken down for their DNA. The ctDNA is at a finer level than the CTCs.
And I think the liquid is an RNA analysis, maybe liquid RNA exosome analysis. You could compare it to this, but I don't think it's exactly the same.
Len, did you freeze on us?
No, I don't think so.
Oh, no,
your picture did for a little while.
Oh, okay. Yeah, this is only anecdotal. There are medical oncologists who still believe that tissue biopsy is the gold standard. And this is anecdotal, but I know someone who had liquid biopsies done by Garden 360, which I know Rick and others don't like, but also by Caris, and both were negative. But then within 3 weeks, they did a tissue biopsy on the same person, and they found several genetic mutations that were actionable, for what that's worth.
So tissue is still the gold standard, according to that.
Well, we know that. My guess is that the tissue that they did it on was soft tissue. Because soft tissue is the gold standard. Secondly, liquid, and thirdly, bone.
Yeah, it was a lymph node.
Yeah, and bone is not great because they have to process the bone in order to get the DNA out of it, and that can distort the results. So the best thing to do is the blood. But what I'm looking at here is something different. I'm not looking at the ctDNA to find the mutations. I'm thinking of the ctDNA as being an indicator as to the extent that the disease is already spreading. That's what I'm seeing the ctDNA as.
It's a quantitative analysis, and that's part of the program I'm in with Foundation, when they're going to take blood. Remember, because,
yes,
Elucid signed me up to that. They're going to come in and draw my blood as a quantitative analysis to determine if there is a level that's detectable of tumor fragments, because my PSA is 0, and they want to see, whether or not I should, at what point I can take a holiday. And if they see tumor fragments circulating around, they're going to discourage me, more than encourage me, because of my metastatic disease.
Right. Thanks, Jack. Thank you. Yeah. So Michael and Cheryl, you can mention to Dr. Rana when you write to her that that FMI is doing a trial at NIH around this ctDNA stuff, because one of our gents is in that trial. And does it have any value? Would the Intera test have any value for you? And,
okay.
I'm throwing it out. It may be useless, but you never know.
Right. And, it's been so helpful in speaking with her in the past, because you have really armed us, to look at so much more and do more research on our own. The tests that the results that you sent us before, and this article that you just sent me, it showed that this is getting off the ctDNA thing. But for the Pylarify, the first time Michael was going to get his a couple of years ago, our insurance denied it. And when we found out, the tens of thousands of dollars they were going to charge, I went on a letter writing campaign armed with materials that you had led me to. And then I dug deep and I ended up writing, I sent them this huge packet of information, and they accepted it and paid 100% for this thing. So on the article you sent me today, it says in there at the end that Australia authorizes these tests at 0.1, and the United States doesn't even pay for them at frickin' 0.3. I mean, it's so gross.
I know. Didn't we get a T-shirt to you that says "Be your own best advocate," Miss Cheryl?
No, but I'm gonna get myself one.
We should have. I thought I'll follow up on that. And we hope that you're filling out the survey to say this. That's what we hope.
Will.
Oh,
we will for sure.
Separately, not together.
Okay.
Separately. He has to do his own. Okay.
So my whole point in that is, when you do come in there and talk, and mention things that are current and up to date, I think the doctors are really encouraged that you're caring about your own health, and that you're not just going to sit there and take what they give you. You're looking to be your best advocate. And, it's none of my business, but, people like James that are new, and I, heard what he had to say and everything. And you guys just really open doors for us and make us feel so empowered. And I just so appreciate that. Some people might think people ramble on, but I like the rambling. So.
Thank you for that. I'm aware of the time, so I'm gonna move on.
Wait a minute. No, you got to give me a chance to talk for a moment.
Oh, Jeff, I didn't see your hand up.
Yeah, Michael, you need to find out if your cribriform is greater than 0.25 millimeters. This is critical because large cribriform is very aggressive. And I was in a seminar Friday where they talked about intraductal, and they said everybody who has intraductal has cribriform. And that if your cribriform is larger than 0.25 millimeters, it is very aggressive. And you need to.
Hey, Jeff, it's 4. And thank you.
4 millimeters?
Yeah, and we know it's aggressive.
Okay.
Thank you.
Okay,
Thank you, Jeff.
Thanks, Jim.
Paul Frieda.
Can I just say, Andrea, I saw you come on for a minute, but we will be closing this meeting out before we get to your MS meeting in 40 minutes. So
I'm always too early. I get
yes,
my times messed up. It's in that
yes,
screen.
yes. We will be with you at 8:30. You're Eastern, aren't you? We'll be with you at 8:30. And it's right
Thanks, Rick.
now, it's 7:45. See you later. Goodbye.
Okay, Paul, please unmute yourself. And then Mark Valens will be after that. Paul? Hiya. Well, I see your face, Paul, and you're not muted.
Not very well at all.
Very, very soft. Can you get
sound like
closer
you're,
to your mic?
yeah, you sound like you're at the end of a 2-mile tunnel.
Okay, try
That's a bit better.
try this.
Bring yourself closer to the microphone.
Got a little better? I changed the microphone.
Well, it's a little better, but it's still not great. But
Now.
Just get closer to it.
Hear me?
Barely.
Now we can't hear you at all.
You turn volume up.
Let's try something else. How about that? Is that better?
No.
Not really. It's okay. It's barely. Yell. Scream. Call in. Call in and leave your phone on. Mute, and come in on the telephone, and then we'll be able to talk to you.
All right. What number should I call?
Go to the reminder, and it's all in the reminder. Check the reminder.
What?
Check the reminder. Pull up the reminder. All of the information is in the reminder or on the website.
Reminder on the website.
Paul, just raise your voice. Can't you raise your voice?
I can talk louder. How about that?
That's it. Well, it's better.
Is that better?
Yeah.
Okay. All right. So I have some information, just an update, and then some insurance information that some people might be interested in. I had prostatectomy 10 years ago, 2014.
We can't hear you again, Paul.
Yeah, you're trailing off again.
Yeah, we cannot hear you. Look, do you get our reminders, Paul?
You can't hear me.
Do you get our reminders?
Oh,
the weekly reminders that we send out every week.
I don't get the reminders anymore. For some reason, I've been meaning to look up for that, but I don't think I get the email reminders. No.
Julian just posted the phone number.
Thank you.
Call in, and while you're doing that, I'm going to get Mark started.
Yeah, and you also need the. I'll put the room key in for you. 222
646-749.
Yeah.
Okay, hold on.
Okay, I'm going to go on to Mark while you're doing that. Mark, would you catch us up a little bit, please?
Well, I just had a biopsy of the adrenal gland this afternoon, and I'm in a whole lot of pain right now.
Oh,
man.
So I don't really feel like talking very much, but there.
Mark, may I?
Yeah, Rick knows as much about this as I do. Go ahead, Rick.
So I'll speak for Mark, and then we could ask him questions, and he can put his thumb up and his thumb down and move on. Now, we talked about Chuck Snyder earlier on, who doesn't make much PSA, but he makes volumes of PSA compared to Mr. Valens, who really doesn't make any PSA and has advanced prostate cancer and went on a trip 2 or 3 weeks ago, a road trip. And the road trip turned out to be pretty uncomfortable as far as Mark's back was concerned. Uncomfortable enough that he was incredibly smart enough to ask for an MRI. And as a result of that MRI, a PSMA, and I'm skipping bits out here, Mr. V, but what we saw on the PSMA was a lot of cancer. A lot of cancer. Now, when I first started talking to Mark and he told me all this showed up on the, actually it wasn't an MRI, it was I think an FDG PET. And when he first said to me, well, we've got it all, of course, I was really concerned, especially given his history, that we were looking at small cell. It was like, you know, these are all the signs, not much PSA, he's had a bunch of treatment, but hasn't had chemo yet, and da, 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 da. But then when we did the PSMA, a lot of this cancer showed up on the PSMA scan. In fact, it was remarked that more cancer showed up on the PSMA than on the FDG PET. So we thought, well, I thought, and Mark and I have been working together, that probably means that right now, even though he may have some disease that has morphed, he's still got a lot of adenocarcinoma, because if it was all small cell, it would not be showing up on the it wouldn't show on the PSMA.
Yeah.
Now, Mark has a GU medical oncologist, Halaborno at UCSF. And some time ago, he had a relationship with somebody at Hutch, Dr. Shea, who I think is actually pretty good, who's now at Hutch and really runs a lab at Hutch, but also has a clinical practice. And he has a local lady, Dr. Sander, who is a general medical oncologist, but he has a wonderful relationship with her, and she's very, very attentive to Mark's wishes. And so, which was one of the reasons why we were able to get a PSMA PET so quickly, because she had some other ideas and we said, no, let's get the PSMA, and they did the PSMA. We also recognize that in this case, she wanted to do a biopsy, and I was less concerned about the biopsy once I saw how much PSMA disease there was. But there was an adrenal gland, and we thought, look, if we can, if first of all, she wanted to do a biopsy in his spine. And I said, no, we ain't doing that. Mark, don't let them come anywhere near you with a needle in your spine, because we don't know the condition of your spine with so much cancer. Not a good idea. And so we switched her to getting a biopsy from the adrenal gland, which is what Mark got today. It's a great place, lymph node. It's a great tissue sample. We're going to send it off to Dr. Roux, because we want his eye to see if he sees any small cell stuff in there. And we're also going to get it analyzed, sequenced, to see if we can see anything else. And we also have reached out to Dr. Agarwal, who is a small cell specialist GU medical oncologist at UCSF. However, it's very difficult because Dr. Borno is already assigned to him, and Dr. Borno is really only there part-time, and she hasn't paid enough attention to Mark over the past year. So we've sort of got Dr. Agarwal looking over Dr. Borno's shoulder. We've got virtual meetings set up. And what I have suggested to Mark, what I would do, the other thing that we've done is we've gotten Dr. Sander to agree to give him 1 dose of docetaxel next week. And what's going through my mind is we got a lot of PSMA disease. We may be morphing. We should strike whilst the iron is hot and get Pluvicto to address all that PSMA disease right now whilst we can. And so if he's done docetaxel and he can qualify for the Pluvicto, he can start the Pluvicto, we can see if we can get a response out of the Pluvicto, and then we can follow up with chemo after that, knowing from that McGill poster that we saw at GU ASCO that maybe chemo is more effective after Pluvicto than before Pluvicto. We don't know that for sure. So what we're trying to do is engineer a situation for Mark where he'll do the docetaxel, will immediately apply for Pluvicto, and then get him into a Pluvicto regimen very quickly. And in the meantime, we'll be doing the best we can to ascertain if small cell is there, because Dr. Zhu will be looking at that biopsy sample from the adrenal gland. Did I miss anything, Mr. V?
You got it mostly right. Dr. Sand was not going to take from the spine. She was going to take from the iliac, which I
from
didn't
the
ilium.
But even so, we convinced Mark and Dr. Sander that a soft tissue sample is better than a bone sample.
And she believed us. She's all on board.
Yeah. And by the way, that comes directly from the mouth of the people at FMI that have told us that, and that's what they would like. That's where they get the best results. And so I don't think we're leading you. I don't think we're leading you on a wild goose chase here. And we're really hoping that we can get Mark onto Pluvicto and get a great response from the Pluvicto, because my biggest concern is if we do docetaxel first, we may lose the opportunity to use Pluvicto, because the disease could morph again, and at the end of a docetaxel regime, which is going to be 18 weeks from now or more, we may not see the PSMA that we see. We may, but we may not. And since we can see the PSMA now, why not treat what we can see with something we know will attack the PSMA cells, and then we can worry about the other cells if in fact they're there afterwards. So that's it. So what comments does the group have?
Sounds like
Sounds like some great navigation. What, Len?
I was going to say, I'm not particularly in favor of using Pluvicto if we know there are non-PSMA active lesions. Presumably, docetaxel would also kill the PSMA positive lesions, since docetaxel is completely non-discriminatory. Whatever is growing, it will kill.
We don't know, Glenn. We don't know that there are non-PSMA lesions. There were more lesions that showed up on the PSMA scan than showed up on the FDG PET scan.
There were more, but
more lesions on the PSMA scan than on the FDG PET scan.
But there were positive FDG lesions that were PSMA
correction,
negative.
It was not an FDG scan. It was just an MRI.
Oh, okay. Forget what I said then.
Well, we're waiting for biopsy results, and that will tell us, I guess, whether there's any small cell transformation, right?
Yes.
Yeah.
Meantime, how about this pain? Did they give you something for pain?
Well, they offered me some narcotics, but I'm going to see how I feel in the morning. Lying here in bed, I'm okay. I
Oh,
just move to get up or to roll over, and I get really sharp pain. But I can make it through the night, and I'll see how I am in the morning. I talked to her nurse, his nurse, and she said he ended up having to cut through a lot of muscle in my back, and so it's not surprising that I'm hurting.
yeah. All right. Well, that's too bad.
Anybody else? And look, I appreciate very much what Len is saying, that if in fact we know that that there are cells that don't express PSMA, then maybe Pluvicto is not the best. But then we also know that docetaxel may not be the best, and we have to switch that chemo regime to something more than just docetaxel. And we don't know that yet. And, if we can get him, and Mark has never had chemo before. So if he's going to go through chemo, why not knock out whatever we can with the Pluvicto? And then we know that we don't know, but there's a study that might suggest that chemo is actually more effective after Pluvicto than before. And so then we come in with the Pluvicto, and then we may have a more effective chemotherapy agent, whatever the chemotherapy is. Dr. John?
Well, we'll be eagerly awaiting your biopsy results then.
I should have a lot more information by next week,
Yeah.
so I'll get back to you.
Okay.
And we're driving up to Seattle to see Dr. Shea, who's really pretty good with a lot of strange cancers. See what we can learn from him.
It's possible that if this is from muscle injury, you might get some benefit from ice. The adrenals are probably too deep for that, but the muscles aren't.
It hurts way inside my stomach, not like anywhere near the surface.
Well, maybe it is the peritoneum then.
Anyways, I'll report back next week, and we'll see what we come up with.
Okay.
Thank you, everybody.
Okay. Is Paul still with us?
I just saw him drop off.
We didn't get a new phone call. I mean, there is someone on the phone, but I think he's been there for quite a while. So Paul may have signed off because of time. We'll have to catch him next week then, and maybe he'll have his microphone problem solved. All right, who has anything that they need to say before we close?
A great job. I have something to say. A great job, Dr. John, coming in just 7 minutes over.
Thank you. Bill, you want to get the last word in?
Just really quickly, when I was talking about my prospective treatment with Dr. Rossi, I forgot to mention when we talked about second opinions, my first opinion was with the Mayo Clinic in Rochester. So I saw Dr. Ryan Phillips there, RO, and he recommended 20 sessions of IMRT. So Dr. Rossi is actually 8 sessions beyond that.
Hold on a minute. And he recommended 20 sessions of IMRT based on a T3A diagnosis?
Which is not enough to cover the whole pelvis and the gland itself.
Well, they said they would do the pelvic nodes and the aortocaval node. I did have a question with them. They said T1C, okay?
Okay, so if they said T1C, then 20 sessions makes sense.
Yeah.
Okay. So, they said T3, it doesn't make sense.
Yeah,
So here's the problem, Bill. You got a moving target, and we don't have a really good definitive diagnosis.
yeah, I myself am confused how the urologist can say T3A. Mayo says T1C, and Rossi says T2B or T2C. How do I make sense of that? Get another opinion, I guess.
Yeah, if you like, look up or I can send you the staging criteria. We can figure it
I
out for
look it up.
ourselves.
I've looked at it before, and it's a bit mysterious to me, I admit, but I had it figured out, some
Right.
time ago. So I'll go back and look. But
Yeah, tell us what you figure out yourself.
yeah, thank you very much, you guys, for your help. I appreciate
Good night, everybody, and thank
Hold
you so
on,
much
hold
for
on,
coming.
hold on. David Muslin has his hand up.
I just want to express my gratitude to everybody on this call for the hard work that everybody does at AnCan. That's all. Just want to express my gratitude and love.
God bless you.
All right,
Thank you, David.
this is James Thompson. This is James Thompson. For my first time, I really appreciate it. I thank you for all the information that you have given me. And now I do have questions for my doctor, and I will be pursuing it. Thank you.
Okay, you stay in touch with that Cliff Collins because he knows his stuff. Okay,
I
and Jim
will.
Marshall, and between Cliff Collins and Jim Marshall, we're gonna get you. We're gonna get you on the right track. And everybody, and especially you people who will be listening to the recording tomorrow or the next day. Please fill out the survey, please. Okay, it's really important to us. Thank you.
Okay.
Next week.
Okay, take care, James. This is Jim Marshall.
Thank you, John. Good night, everybody.
All right. Thanks, everybody. Thank you.
Good night, everybody.
Night, everybody.